Hi, I am so pleased to be here today. My name is Alicia Morgans, and I am the medical director of the Survivorship Program at Dana-Farber Cancer Institute. And I am thrilled to be talking with you today about how to achieve and maintain a healthy lifestyle with a diagnosis of prostate cancer. This is our outline of what we'll be reviewing, discussing things like cardiovascular disease, impaired insulin sensitivity and diabetes, osteoporosis and fracture, and psychological complications that can absolutely affect patients even more so sometimes than the medical complications. I'll briefly mention some nutrition and lifestyle considerations, and then some aspects of the Dana-Farber Survivorship Program that I think can be useful whether you're at the Dana-Farber or whether you're somewhere else and are just looking for some resources. Importantly, this talk is really going to focus on complications of more advanced prostate cancer because it's really focused on how we think through androgen deprivation therapy, which is a medical treatment for prostate cancer, sometimes given with radiation treatments and other times given when prostate cancer comes back or has spread more outside of the prostate. So I'm talking actually not really about things like radiation complications or surgery complications that are also absolutely important, but not included in this talk. So as a background, prostate cancer is the most common cancer in American men in the United States. And in 2022, we're expecting almost 270,000 men to be diagnosed with prostate cancer in the United States alone. That's a huge number of people. And although people often talk about this being something that, is really a disease of older men that they live with and aren't really suffering from in terms of having advanced prostate cancer that could ultimately be fatal, it still is the second leading cause of cancer death in American men, with nearly 35,000 deaths expected in 2022. So there are many men who have more advanced prostate cancer and many that are suffering not only from the earlier side effects of things like radiation and of surgery, but of medical effects from medical treatments. And it is a serious illness that we need to support people through and not downplay what they may be experiencing. Although 90% of patients approximately have a diagnosis of localized prostate cancer that's all still in the prostate, up to 40% of patients can actually develop recurrent prostate cancer. And of course, there's about 10% of patients, or just under that are diagnosed with advanced metastatic prostate cancer at the get-go. So many of these individuals can be treated with this androgen deprivation therapy, or ADT, which is a medical treatment that can cause the complications that we're going to discuss. ADT, also called hormonal therapy, is more than just lowering testosterone. And the reason that we want to lower testosterone is that it is the driver or the fuel for prostate cancer cells to grow, thrive, survive, spread, and cause trouble. When we lower testosterone levels, we're starving those cancer cells so that they can't do the things that they want to do. And hopefully, many will die and others will go into a deep hibernation. And of course, that's what we want in treating prostate cancer. Shut it down so it can't cause trouble. But when we lower testosterone, we cause complications for the person because men have side effects related to losing that male hormone that gives them energy and muscle mass. And importantly, because testosterone in men is converted to estrogens, men also have levels of estrogens that are lower than that of postmenopausal women. So they have extremely low levels of both of these hormones. And this is where we see the complications stemming from, both low testosterone levels and low estrogen levels. So let's dig into the medical complications of this hormonal treatment. Importantly, cardiovascular disease is a leading cause of death in the United States. And here you can see that even when we combine all cancers, heart disease is still a bigger killer. And that's why it is so important for us to think about treatments that may increase the risk of cardiovascular disease in our patients. Now, certainly patients who have prostate cancer are also, in many cases, aging men. And being a male and having an increasing age is actually another risk factor for cardiovascular disease. So men with prostate cancer are still men who are just getting older day by day, and they have both prostate cancer to deal with and a risk of cardiovascular disease. It's pretty common in this population. More than that, androgen deprivation therapy treatment that I just mentioned as lowering testosterones and estrogens affects cardiac risk factors. So it causes an increase in cholesterol levels. It causes an increase in triglyceride levels as well. It causes an increase in fat tissue around the middle, and it causes us to have impaired glucose metabolism, which just means that things like insulin in the body that are meant to take sugar from the blood and get it into muscles and package it so that it can do the job of fueling your body, that insulin is no longer as effective as it normally is. And sugar levels can go up and people can get things like prediabetes or even diabetes, especially if they're on the edge of that diagnosis with exposure to androgen deprivation therapy. And here we can see two CAT scan panels, just sort of middle images of a cut through the middle of an individual patient. And what we can see on the left is a gentleman who's never been exposed to androgen deprivation therapy. He has a relatively big muscle component around the front of his body with those lighter gray colored muscles that my kids often refer to as a six-pack. And when we look on panel B, you can see those light gray colored muscles are very thin because he's lost that muscle mass. And the darker blackish gray band around all of that, which is actually fat tissue, has increased quite substantially all around the whole middle from exposure to androgen deprivation therapy or ADT. Cardiovascular risk factors are actually really common in men with prostate cancer. There was a study a few years ago in which every man who came into the prostate cancer clinic was assessed in terms of cardiovascular risk factors. And of that 100 patient group, we found that, or not us, but it was found that coronary artery disease or heart disease was really common. And the risk factors for it were really common, with high blood pressure or hypertension present in 60% or just under 60% of patients, cholesterol problems or dyslipidemia present in just about 50% of patients, and diabetes present in 17% of patients. And 17% of patients also had a history of heart disease itself. Some had had stents, some had had surgery called a cabbage surgery, bypass surgery to try to fix heart disease. And only 4 out of the 100 men coming in for a prostate cancer visit did not have any cardiovascular disease or risk factors. So most people had something. The NCCN is a guidance group that helps us as doctors understand how to best care for patients. And importantly, they help us understand how to deal with it, not only treating prostate cancer, which is a main focus, or treating all of the other types of cancer that we treat, but also how we deal with complications of surviving with different cancers. And they have a specific section on dealing with cardiovascular disease. What they suggest to us as physicians is to help patients through a very systematic approach, an A, B, C, D, E approach that you can see on this slide. And thinking through this systematic approach helps us make sure that we check all the boxes in terms of counseling our patients and assessing all of the problems that can arise from hormonal treatment or ADT. So we need to make sure that we understand that there's a risk, raise awareness of cardiovascular disease with our patients, take care of assessing and counseling patients on their blood pressure, and engage either with a primary care doctor or a cardiologist or a cardio-oncologist, a heart doctor who specializes in cancer patients, to try to make sure that we're dealing with blood pressure if it's not adequately controlled. Really, the goal there is about 125 to 130 over 80 as a blood pressure. So if you find that you're over that frequently, that's something to talk to your primary care doctor about. We also have here C, cholesterol, making sure cholesterol is assessed, whether maybe with the primary care doctor or the cardiologist, but making sure that's being checked, and that cigarette smoking is something that we're trying to stop, cigarette cessation. So in whatever way, whether it's early counseling, just to put the thought into someone's mind, or whether it's prescribing a medicine or a program to support cigarette cessation, that can be really effective in reducing heart disease risk. Also, D, diet and weight management, so encouraging healthy eating strategies, as well as screening for diabetes, which again could be a partnership with the primary care doctor or an individual's cardiologist. And E, encouraging exercise, absolutely something that patients can do to just get moving and reduce the risk of heart disease. So this is our strategy, and it is something that is updated every year to make sure that we're really getting that message out to patients and to clinicians on how to deal with the heart disease risks. I also mentioned in that conversation that we can have issues like prediabetes or diabetes resulting from hormonal treatment. And impaired insulin sensitivity and a diagnosis of diabetes is on one of the major causes of death in the United States for men. As you can see here, it's much lower than heart disease and cancer, but it is still absolutely one of the top causes of death. We see here at 3.1% of deaths each year. Androgen deprivation therapy was shown several years ago to be associated with an increased risk of diabetes. On the far left of this panel, we can see that incident diabetes is more common in patients who are getting ADT, represented on the chart by GnRH agonist treatment. And we can see here that's highly statistically significant whether patients have that GnRH agonist medical therapy or whether they have an orchiectomy, which is a surgical way to provide ADT by removing the testicles. Either way, diabetes is more common in patients who are being treated with hormonal therapy for prostate cancer. That NCCN group has also, as I said, incorporated diabetes counseling and screening into their recommendations around cardiovascular risk. So again, they want us to engage with primary care, geriatricians, endocrinologists, whoever it is who can manage diabetes, but that we as oncologists partner with those team members and that patients themselves, again, are aware of this issue so that they can have good diet and lifestyle interventions and sometimes medical management for the development of diabetes. ADT also puts men at risk for developing osteoporosis. This is really important, I think, because we as a society commonly think of osteoporosis and aging as being issues that women deal with when they go through menopause and their bones start to thin. That thinning of the bones also happens to men, and especially happens to them when they're taking ADT. So why does this happen? Well, the skeleton is actually really disrupted by these hormonal shifts, and low estrogen levels, among all other causes, low estrogen levels are really what shuts down the balance of bone buildup and breakdown that's always happening in our skeletons and shifts it in the direction of bone breakdown more than build up. 1 in 5 men over the age of 50 will develop osteoporosis. So as I said, it's not just an issue of older women. And the incidence of osteoporosis overall increases with age. So aging men with prostate cancer on ADT are at higher risk of developing this osteoporosis. And here in the picture, you can see osteoporosis is really this thinning, dramatic thinning of the bones so that we don't have that solid structure on the left of normal bones, but really this structure filled with holes. So we can see here a fracture on the right. This is a femoral fracture, that long bone that leads from the hip down to the knee. Again, not only an issue for women, 20 to 25% of these hip fractures and femoral fractures occur in men around the world. And so importantly, the risk of dying in the year after a fracture is twice as high for men, especially in the first 6 months after that fracture, but that continues at all time points after that fracture. It's a higher risk of death after fracture than women. And hip fracture causes lots of complications, even if someone's still living after that fracture, a loss of mobility, loss of independence, and absolutely financial burden. People become more dependent on others, which can be expensive and actually can be really difficult for one's sense of well-being. So the NCCN, again, has given us as physicians bone health guidelines that have been developed in combination or in collaboration, I should say, with the National Osteoporosis Foundation. And these guidelines suggest that anybody on ADT should take supplemental calcium, about 1,000 to 1,200 milligrams every day, not just in a multivitamin, a specific supplement for calcium. And vitamin D3, 400 to 1,000 international units every day. And again, this is something that they should do on a maintenance basis. Sometimes people have a vitamin D deficiency and need to take a higher dose of really high levels of vitamin D once a week for 6 to 8 weeks to replete the stores of vitamin D, and then they would go on this maintenance dose. So that's something to really talk to primary care doctors about to make sure that that's being built up properly. We also have additional medications that we sometimes give to people who have a very high risk of developing a fracture and osteoporosis related to ADT. There are calculators that physicians can use to try to guess someone's or estimate someone's fracture risk. And I would say that one of the ways we do that estimation is also by getting a bone density test. This is different than a bone scan, which we use to understand if prostate cancer has gotten into the bones. A bone density test is a series of a couple of x-rays to look at whether the bones are starting to get really holy or whether they're still dense and full like a normal healthy bone. And the people at highest risk need to have those bone density tests. So anybody who's older, anyone who's has a history of heavy alcohol use, current smoker, or sustained exposure to steroids, in general, that bone density test should be given to most everyone with androgen deprivation therapy if they're going to be on treatment for longer than a year. And that's also important because most of the guys with prostate cancer who get treatment with ADT end up being over 60 to 65, so may have some level of thinning of the bones just related to age. What about the psychological complications of ADT? Absolutely, having a diagnosis of cancer can put someone at risk for depression. Here we can see the impact of depression in the US, with this map suggesting that there's a relatively high rate of depression across the country, in most areas having prevalence of around 7 to 9% or more of individuals in the general community having a diagnosis of depression. And certainly the pandemic has not made those levels go down. If we look to the right, you can see the prevalence of major depressive disorder in association with disease suggests that people who have a diagnosis of cancer also have a substantially higher risk of developing depression, with about 40% of people with a diagnosis of cancer potentially meeting criteria for having depression. And this, of course, we know can come and go, change over time. So something we need to be aware of and support our loved ones who have this diagnosis of cancer and help them identify if they do have depression, or certainly if we ourselves are feeling a low mood or disruption in sleep, or the way that we eat, or our ability to focus and concentrate or get pleasure out of things that used to make us happy. These could all suggest that we're developing depression, not just feeling sad or tearful at times. So prostate cancer itself can put someone at risk for depression, but ADT, this medical treatment, also increases the risk of depression. In this particular study, we had about 40% of patients had an exposure to ADT, and the rest did not have exposure to ADT. And what we can see is the people on ADT in the yellow line had a higher risk of having depression over time than people without exposure to ADT in the blue line. So there's a 23% increased risk of depression with ADT as compared to a diagnosis of prostate cancer without ADT exposure. ADT in one study has also been identified as potentially causing some cognitive decline or associated with a cognitive decline. In the blue bars, we can see the percent of individuals who has impaired cognitive function increases slightly over 12 months, whereas people not exposed to ADT actually had a learning effect, so had improved ability to complete those brain game type studies that help us understand how well someone's thinking, cognitive testing, so that by 1 year, there's a significantly higher level of patients who were exposed to ADT having some cognitive decline or slower thinking than people who were not exposed to ADT. I would say the jury is still out on this. Whether ADT is associated with dementia or things like Alzheimer's is really not clear. However, it's something that we're testing and something we should be aware of, because even if it's not an issue for the entire group of men with prostate cancer, someone who has a high risk of dementia may be at higher risk of getting ADT associated cognitive change. And then again, that's something that we're still trying to figure out. That same NCCN guideline organization has put forth some information guidance for us as we think about trying to identify whether an individual is developing depression or cognitive change. And here we can see that the questions that should be asked, these screening questions about worry, anxiety, sadness, depression, things like feeling withdrawn, not taking pleasure in things that used to make you happy. And then the other things difficulty concentrating, sleeping difficulties, and eating significantly more or significantly less than usual. These are all things that can be associated with the diagnosis of depression. So there aren't specific screening recommendations for depression associated with prostate cancer, but these general questions are something that we can absolutely use. And importantly, as it relates to depression, there are effective treatments available, things like exercise, counseling with a psychologist or a social worker who is trained in treating someone with depression, as well as many options actually that are medical, so pharmacologic, things like pills. And there are so many different options that you can really choose the treatment of the pill, if that's what you're using, that will be associated with certain either activating, energizing type qualities, or some that help you sleep better at night, or some that help give you more or less of an appetite. So there are a lot of options with these antidepressant type medications, and something that primary care doctors and sometimes oncologists can give to someone to help make them feel better. When we have effective treatments, we want to give them out, but it's going to be really that acceptance by the patient and that shared decision with the doctor to actually help make people feel better. And we know that they can. There's not a specific screening tool recommended for the identification of cognitive change or early dementia, but certainly conversations, if that's of concern, can be had. And those conversations can sometimes be most helpful with an individual patient's loved one, because sometimes loved ones recognize or notice these things more than the patient himself. And we can absolutely, as oncologists or urologists, recommend or refer a patient to a neurologist for a full evaluation for dementia. And earlier intervention for dementia is always more effective than when someone has had a lot of decline. So something to be aware of and identify as soon as possible. So let's think about some lifestyle considerations. Patients always ask about this. There's a really nice book on the Prostate Cancer Foundation's website. It's a resource for patients and a guide that's listed there on diet and lifestyle recommendations. And here are some of the tables from inside this book, really going through different interventions like exercise and keeping weight under control, doing things like stopping smoking, and considering medicines for diabetes like metformin, or for cholesterol issues like statins that might be helpful in reducing the risk of complications associated with medical therapy for prostate cancer and keeping someone's heart healthy. There's also a lot of dietary recommendations that are listed here to the right, and the strength of the recommendation is illustrated by the star rating. So eating things like fish instead of red meats rich in fat, eating things like healthy sources of dietary fat like avocados is also really helpful. Cruciferous vegetables, as is listed here. There's a lot of different options here, but I think most importantly, just being aware, trying to have a heart healthy diet will be a prostate healthy diet for sure. At the Dana-Farber, we have some resources that I just wanted to make everyone aware of. We have a survivorship program that I think is extremely robust and actually is always looking for feedback to be more responsive to patients. We focus on clinical care, research and survivorship, education programs for other physicians and team members who are practicing medicine and trying to provide some survivorship care, as well as patient outreach and education. Here we can see the survivorship patient website, which I think is a phenomenal resource, and just wanted to walk through a couple things on that website. This is the site address here, and please feel free to visit that if you are interested in resources or webcasts that may be of use. Here is an example of our event and news. You can see from March, we had a talk that was given by Dr. Hamnovic, and this was on cancer screening in the LGBTQ community. We've had many different presentations, including one on prostate cancer, but also on breast cancer, on tobacco cessation, as you can see here, by Ms. Morales, one of our social workers who focuses on tobacco cessation, as well as on sleep and on so many different aspects of cancer survivorship. And these are all housed in viewable webinar library area where you can really look at these on demand. So please consider going and checking this out if you have interest, and certainly you can join the live events as well. There are also resources for patients on healthy living and mindfulness, as an example here on the website, treatment side effects and some different aspects of caring for yourself as you're developing things like chemo brain or neuropathy or swallowing programs for problems, for example. So many things here, as well as sexual health and fertility, which I think is sometimes overlooked when we're thinking about supporting patients, but absolutely an issue, and in some cases more of an issue than others, but something that we need to also address as we're living well after a diagnosis of prostate cancer. So in summary, survivors living with or after hormonal therapies are at risk for cardiac, metabolic, skeletal, mood, and cognitive complications, among many other effects. Current strategies engaging multidisciplinary teams can reduce morbidity and mortality and improve quality of life. We can work together with other doctors, cardiologists, endocrinologists, geriatricians, primary care, and really support people to live well while they're living with cancer. And employing interventions known to reduce cardiac risk in particular, especially diet and lifestyle approaches, can have a positive effect for prostate cancer survivors and certainly can help their cardiac health. So this is something that should be a goal as we're trying to make ourselves, again, feel well after that diagnosis. So I thank you so much for your time, for your attention today. It has truly been a pleasure. Thank you.